you over the next 40 minutes or so, really a journey of my career through the eyes of acute heart failure. It's an interesting journey. It's one in which there are many lessons for all of you in the field of cardiology about how negative and neutral trials can actually improve the outcomes of patients and really allows one to understand that science can be self-correcting if you learn and understand how trials, particularly negative trials, can influence the direction going forward for the purpose of really helping our patients with being the centricity of everything that we want to do in heart failure. These are my disclosures, and let me go back here. We all recognize the importance of mentoring, and I was extremely fortunate. I came from the University of Maryland to Duke as an intern, and was there for over 30 years. And I was very fortunate that Dr. Greenfield on the left was the chief of cardiology and chair of medicine for a large part of my career. And I was the first fellow under Dr. Califf when he started his young career at Duke. And really, these two gentlemen had enormous influence in the way that I think about the world, the way that I think about clinical research and the care of patients. We all recognize that heart failure continues to be an important societal healthcare issue. I saw a recent report that will be coming out that the global mortality rate of heart failure is actually increasing. We know that heart failure hospitalizations represent an event for a heart failure patient, and that event changes their course of their life over the subsequent years, with increased risk of readmission up to 30 to 50%, and an increase in mortality, which is really interesting because many of us growing up thought, oh, heart failure was somebody got sodium loaded, they needed to come in and get diuresed, and then they would go out the hospital and they would be on their same course. Well, Califf and Dr. Greenfield, who were both in the acute coronary syndrome space, pushed me to say, listen, isn't a heart failure hospitalization somewhat like an ACS for stable ischemic heart disease? And that is, when that happens, when it changes the course, the natural history of the course of that patient. And even prior to Dr. Greenfield, his mentor was Dr. Eugene Stead, who was really the first heart failure doctor at Duke. And he wrote this paper in Circulation in 1940, The Effect of the Application of Tourniquets on Hemodynamics of the Circulation. And they had taken heart failure patients in the hospital, put measured hemodynamics, and then put tourniquets on it, and was able to show that they could improve dyspnea, reduce the wedge. But once you took the tourniquet off, there was transient rebound. And what I will say to you, in the first sort of 10 to 15 years of investigation of pharmacologic therapy, the therapies were probably not much different than a tourniquet, a pharmacologic tourniquet, and you'll see why. Well, as a fellow and junior faculty, we began our journey with appropriately named the first study. This was a trial of epoprostenol in patients with hospitalized advanced heart failure. And it was we thought this was an absolutely ideal approach for these patients because the hemodynamics were acutely improved with epoprostenol, prostacyclin, and it had been very effective, as you all know, in pulmonary hypertension with normal ejection fractions. But lo and behold, as this trial went on, it was stopped by the Data Safety Monitoring Board, and for increased harm And it was shocking to think that one of the first times I experienced that acute surrogate endpoints all going in a favorable direction were not demonstrated with clinical benefit. Well, this database became a rich database for us to explore and to understand acute heart failure. And one of the real interesting observations we made in a non-randomized but an adjusted analysis is we looked at dobutamine use in that trial. And here we show that dobutamine, which we were using very commonly at this time, was associated with an increase in mortality in these acute heart failure patients. And so we began to think about whether there was an issue of myocardial injury that could be going on when one was hospitalized with heart failure, and that is through multiple different mechanisms could myocyte death be occurring when one was hospitalized and resulting in the release of cardiac troponins and other markers. And so we began to say, okay, if dobutamine and prostacyclin don't work, let's look at an inodilator, milrinone, which had been approved for management of acute heart failure based on hemodynamics. And let's look at this in hospitalized heart failure patients. This became one of the largest hospitalized heart failure patients at the time, 48-hour infusion of milrinone in just under 1,000 patients. And lo and behold, to our surprise, six-fold increase in adverse events, mostly driven by sustained hypotension, and no advantage on rehospitalizations, and there was almost a 20% increase in mortality, and this is at 60 days. So a surprising result with a drug that we were using commonly instead of dobutamine at that time. And so we took a step back and said, listen, we have to understand acute heart failure better. And so we, working with Lynn Stevenson and Rob Califf, an NIH effort was put forth called the Escape trial, in which we randomized 430 patients to receive PAC guided therapy versus expert clinical assessment, and looked at 6-month outcomes. And the hemodynamics were significantly improved in the PAC arm. We didn't know what the hemodynamics were in the clinical arm. But as you can see here, wedge pressure down from 25 to 17, index up significantly in SVR, dropping into the normal range. And so we were excited about these intermediate endpoints. But then lo and behold, left panel, no difference in days alive out of the hospital versus the clinical care arm. And there was an increase, almost a twofold increase in adverse events in the PAC catheter arm. And so once again, we challenged the dogma of routine PAC catheters in heart failure, hospitalized heart failure patients, to say we have to take a step back and maybe it's not all about hemodynamics. One of the things that possibly explained these differences was it looked like, and this is very early on, the natriuretic peptide levels in both the clinical care arm and the PAC catheter arm were about the same change, and certainly close to each other at discharge, about a third drop in both arms. And this again suggesting that perhaps the PAC catheter for 48 hours was good, but once you took the catheter out, was this essentially were we back into the tourniquet situation again? And from this rich database, we also saw Yuri Ilkayem published a nice paper showing that, again, the inotropes look to have more harm than the vasodilators in this population. Well, we learned a lot from these neutral trials. We were able to understand that what the predictors were of bad outcomes in these patients. And as you can see, a number of things that come to mind. And these all led, as you'll see, to interventions from this simple risk score. So renal function, 6-minute walk, so challenging exercise, hyponatremia, and then beta blockers and natriuretic peptide levels, or the lack of beta blockers. So where did we want to go? Well, we still didn't have any effective therapies for acute heart failure. So we said, listen, here's a new therapy out, Naseritide, kind of a vasodilator that had some features that were perhaps less toxic than pure vasodilators like prostacyclin. And we did, using the troponin hypothesis, we did a pilot study of Naseritide versus dobutamine. This is an investigator-initiated study. And we're able to demonstrate that indeed dobutamine was associated with higher troponin release than Naseritide, and people would perhaps suggest that this might be an intermediate endpoint that could help us understand whether a therapy is beneficial or not. Well, at this point, we realized that we had learned a lot from some negative trials. First of all, we learned that we needed larger sample sizes. We learned that acute hemodynamics was not a reliable target to improve clinical outcomes, and acute short-term therapy was mostly behaving like a pharmacological tourniquet. We also learned that less congestion, you see from that model reflected in the BNPs, had better outcomes, and that actually, even with neutral trials, you can save lives by avoiding toxic therapies, routine use of PSE catheters, and inotropes and other agents. And so, talking about larger studies, we said, okay, Naseritide was now on the market based on the VMAX study and was being used extensively. And reports became coming out. Well, was there some renal dysfunction? Was there actually a adverse mortality signal? So we convinced then Johnson & Johnson, led by Dr. Brunwald and Dr. Califf, to do a mega trial, the first mega trial in acute heart failure, which looked at 9,600 patients. And this is the type of size of study you need to see if clinical endpoints at 30 days, death or heart failure rehospitalization, were influenced by a short-term infusion. We also obviously looked at dyspnea, but that had been already approved for a dyspnea reduction. And lo and behold, the dyspnea results on the left showed that there was really only a clinically marginal improvement in dyspnea in the treatment group versus placebo, both at 6 and 24 hours. While they looked statistically significant, we had asymmetrically split the alpha so that these actually weren't statistically significant. But more importantly, the right panel showing no benefit on mortality, rehospitalization for heart failure, or the combination of those. And this really led to the end of the Naseritide era, where this was being routinely used, almost $1 billion therapy in the market. Well, we didn't give up. We were stubborn, and we still thought natriuretic peptide therapy could be of benefit. And so there was another agent called Untitled, and this was one in which had perhaps a more favorable effect on renal function than Naseritide did. We did a large randomized trial. And lo and behold, again, no difference in cardiovascular mortality, and the clinical endpoints were also neutral in this. So lots of negative trials, but we didn't give up. And relaxin was an exciting agent that you're familiar with. It was a naturally occurring peptide found in men and women, but a normal hormone of pregnancy. And it had a really good safety profile and seemed to be associated with very favorable cardiovascular and renal hemodynamics. And amazing sort of development program. This was their phase 2B study of 1,100 patients. That's a large phase 2B. And they were able to show that it did indeed improve dyspnea on the from baseline of about 20%, looking at the area under the curve between serelaxin and placebo. Another scale that was used in the study wasn't as favorable, but all the biomarkers went in the right direction. There was a significant prevention of rise in troponin. There was natriuretic peptides looked more favorable, as did cystatin C. So everything was looking favorable. And lo and behold, when you looked at cardiovascular deaths and all-cause deaths, a favorable had effect of about a 37% reduction, statistically significant. Obviously, when you see a trial like this with 1,000 patients, you ask the question, well, how many events were there? And there are only about 100 events. And so, as you'll hear, 100 events is really in an uncertain area. So that's why we did the ASCEND with such a large sample size, because you cannot be certain, even with this such a favorable finding. This went to Cardiorenal Advisory Committee, which I serve on now. I wasn't there at the time, and it was rejected by the advisors, mostly because the events were small and the dyspnea scale was conflicting, two different conflicting. Well, they were asked to do a larger study, 6,500 patient study, and to look at mortality, since they had that mortality signal. And lo and behold, when you do larger studies and you now have close to 600 events, the hazard ratio is 0.98, essentially identical to placebo, which was very disappointing again. So this was the history of drug development that I had been involved with. It was not very favorable. When I was going up for tenure, the committee was thought that my therapeutic development guidance was associated with mostly negative trials, but was able to convince them that you learn a lot from neutral and negative trials. And this, we wrote about this in the journal, why negative trials are positive for heart failure patients. But look at this analysis. I think this is really important for this residents and fellows to see this. Here's 3 heart failure trials. These are chronic outpatient trials. Elite 1 and 2 was with losartan, and Praise 1 and 2 with amlodipine. The first trials at the top of each of those therapeutic areas had sample sizes, as you can see, under 1,000, and event rates that were just about 100 or less, or 50. And they had very favorable findings. You see 46, 62, 46% relative risk reduction. They did the exact, they were asked by the agency to do confirmatory trials with endpoints that exceeded 500. And you can see that they found the exact opposite finding with these therapies, actually all heading in a harmful direction. So really important lesson that you need a large number of events. It's not the sample size, it's the events that gets you in to there. And this chart shows this. Salim Yusuf published this a long time. I love this chart. The number of events that would be satisfactory for a patient population that had a 10% mortality, that's about the 30-day mortality for acute heart failure, would be between 350 and 650 to be adequate and to really begin to avoid a type 2 error. But when you get really significantly less than that, like that first relaxin study, you really are getting in trouble. Well, Caliph, my mentor, I met with him and he said, why can't you conduct a positive heart failure trial? And so we went back to the books, and Mike Felker, my fellow and faculty member, and I, through the NIH Heart Failure Network, which we were a site, designed this study called the DOSE trial. And we said, listen, let's just go back to square one. We don't even know how to dose furosemide in acute heart failure. So we designed a 2x2 factorial design, low dose, and then 2.5 times the oral high dose. And the factorial design was give it as a Q12 IV bolus or a continuous infusion. Well, what we found is that there was no difference between the bolus and continuous infusion. And as you'll see, high dose seemed to have a really important effect. Now, we chose this patient global assessment as the primary endpoint. You can see we just missed on a nominal p-value there. But p-values are not meant to be a cliff, particularly when you're doing a trial of this size, which really would be considered a phase 2 study. And when you look at the totality of secondary endpoints, they all favor the high dose intensification. Dyspnea was statistically significant by AUC, a twofold freedom from congestion, 2 more pounds of weight, net volume was in a favorable direction, almost a twofold change in NT-pro. There was a transient increase in creatinine. But that came back to baseline, as often does. And importantly, for more and more from when you working in health systems, the length of day stay was shortened by a day, which is a very important finding. So all in all, the totality of the dose trial was for really a modest-sized trial, has been impactful and changed the guidelines, suggesting that we should be at higher doses. Well, we recognize that that can't be the end all of a clinical trial, a trial with just over 400 patients. And so Rob Mentz, my former fellow and faculty member now, and Eric Velasquez, former fellow and chief of cardiology at Yale, and I helped design this TRANSFORM trial. Eric and Rob are running it. And this is a really cool trial because it's testing the hypothesis that torsemide, which in phase 2 studies had favorable effects on fibrosis and other markers that look more, even in randomized trials, look more favorable than furosemide. Would that really pan out in a large-scale trial? And this is being done as a registry trial, a very simple trial where there's central coordination and follow-up, primary endpoint mortality, and enrolling exceedingly fast. We should have the results of this, I would expect, in about 18 months. Well, what did we learn then from all this course, and sort of how do we land this discussion for you? What we learned is that we probably have to go longer with therapies than just 48 to 72 hours. It's real. This is not thrombolytic therapy. We don't have a ruptured plaque and a thrombus in acute heart failure. We have multiple mechanisms, and we can't expect a 40 to 72 hour infusion of a drug to provide 30 to 100 day advantage on morbidity and mortality. So we took a step back and started saying, let's take therapies, initiate them in the hospital or in proximity to a hospitalization, and then continue them for prolonged periods of time. And that's what we did with vericiguat, soluble guanylate cyclase stimulator. And, this large-scale study of over 5,000 patients randomized against placebo, very good background therapy showing a 10% reduction in cardiovascular death and heart failure hospitalization in a high-risk population. That 10% turns out to be a lot of patients who benefit from it, even though the hazard ratio looks more modest. What was interesting as we think about personalized medicine and trying to untangle these large heterogeneous patient populations in trials is that we had pre-specified a quartile analysis around NT-proBNP and the clinical outcomes. And what we found is that in patients who were in the lowest 3 quartiles, the less sick patients, and this was at cutoff at less than 4,000, not only did we see a much stronger relationship on the primary endpoint, you see the hazard ratio now 0.77, but mortality was significantly reduced in these 3 quartiles. Well, this is very intriguing, and this has led the sponsors to say, listen, we're going to do a follow-up trial in this lower 3 quartile range of NT-proBNP, which is, I think, very exciting. Well, you've seen this information. The ARNIs, obviously, a big win in clinical heart failure. Eric published with Dr. Braunwald the initiation of an ARNI in hospital with a primary endpoint of NT-pro showing a very favorable effect in the short term on NT-pro, and the clinical events went in the right direction. So supporting that one can initiate an ARNI in acute heart failure, but not real sick patients, right? We just heard the LIFE trial, not yet published, but presented that in the class 4 patients who were hospitalized, the ARNI was showed no advantage over placebo. And then we have omecamtiv mecarbil, the cardiac myosin activation drug. Again, initiation at hospitalization and proximity to hospitalization, showing in this high-risk population a kind of a similar outcome as vericiguat, and that is about a 10% reduction in the primary endpoint of CV death, heart failure hospitalization, and no effect on CV death. But in a pre-specified sub-analysis presented at HCC late-breaking journals by John Teerlink, low EF patients, maybe the sicker patients, seem to have an augmented benefit. So we might be able to tailor these two new drugs, vericiguat and omecamtiv mecarbil, above and beyond sort of our traditional 3. Now, this is out there too, and there's confirmatory trials coming in, but iron therapy, looking at ferric carboxymaltose for iron deficiency at discharge in acute heart failure, showing a very favorable effect on total cardiovascular hospitalizations and CV death, or mostly driven by total heart failure hospitalizations. I think this is interesting because this is a different type of therapy that's not going to be influencing the blood pressure, and it's going at a total different access, but more to come on this therapy. And then we have to give a lot of credit to the SGLT2 inhibitors. Great signals coming from these chronic trials, and dapagliflozin, empagliflozin, both showing reductions in morbidity and mortality. And sotagliflozin, and this was in patients who had recent worsening of heart failure and showing a favorable effect. This was restricted to those with diabetes and heart failure. And so when you look at the analysis of patients who've been recently hospitalized and stabilized, the effect remains strong. And so I think we're going to see adoption of this class of drugs into the guidelines now, really moving for drug class as standard of therapy, and then perhaps vericiguat, and we'll have to see with omecamtiv that they might be used for rescue therapy. Well, I'll just close up on the trial journey. That is, as Ebru mentioned earlier, we had done a large work in the stable outpatient group with HF Action. Those are hard trials to do when you do exercise therapy and heart failure. And we kept our investigative group together since HF Action. Delane Kitzman and I were fellows together. Dave Whalen was one of my first fellows. He's at Jefferson now. And we said, after we did the HF Action, we said we need to get more proximal to a hospitalization for heart failure, but we can't just have somebody who's come in with acute heart failure, running on a treadmill like we did in HF Action at a fairly vigorous rate. And so Delane and his geriatrics team at Wake Forest devised an intervention that was multimodality. And it was one that used physical therapy. It used 4 performance levels and measured 4 domains of physical function so that you had a 16-cell grid. And the exercises progressively were billed to be more intense and they were focused around balance, mobility, strength, and endurance, and with really goals to not only improve exercise tolerance, but be more stable, avoid injuries and falls. And so this intervention was done in the Rehab HF study, and started hospital-based, and then 3 times a week facility-based, and then home-based, and maintained home-based up to 5 times per week. And we looked at a endpoint looking at physical function, and 350 patients, roughly old, 73 years old, great recruitment of women, 51%, and underrepresented minorities, lots of comorbidities, and what the primary endpoint of this SPPB showed a significant improvement, a meaningful improvement in this scale of physical function of 1.5 points, with a significant difference would be 0.5. And as you can see, really not much difference in the usual care arm. And these are the components of that. And as you can see, over time, as you move from level 1, which is red, to green, that's as that dominates the picture, that shows that there's been significant improvement in all domains. Balance, strength, mobility, and endurance showed improvement. And clinical events were too small to show differences in these in this group. And so this is a study, while being a phase 2 study is how one would categorize it. We have put forth to the National Institutes of Aging a phase 3 study of approximately 1,000 patients that would address the clinical endpoints. So in this Rehab HF, we saw a large improvement in physical function, the short physical performance battery, and large improvements in 6-minute walk, quality life, frailty scale, depression, and no difference in clinical events. And so more to come on that, but I think looking at different ways, not only drugs, but devices and non-pharmacologic therapy to treat acute heart failure will be very important. So what's the direction we're going? We really have to change the research culture in the United States. And one of the things that we have created is called the Heart Failure Collaboratory. This is a private-public relationship with the FDA, in which we have multiple stakeholders working together to improve therapeutic development, whether it's device, drugs, non-pharmacologic therapy in heart failure. And we recognize that clinical trials in the United States has been unappealing to patients, unappealing to investigators, been too complicated and high costs. And so we're addressing these with multiple working groups that you'll see periodically publications from this group. And I think this is where we need to take this journey that we've been on. We can't just keep doing the same type of trial over and over. We've got to do things differently and better. Transform is one way to move in that direction. And I would say that the most important thing from this journey has really been the mentoring and the work with young people and really instill excitement about the field of heart failure and the field of asking questions. And I've been privileged to work with many of these people over the years and watch their exciting careers take off. And also with the journal. And the journal, I've had a chance to mentor and work with terrific people at Jack Heart Failure. And this is, we got a little casual here on one of our editorial meetings after we did all the work, but it's the lessons learned from the journal really apply to everything we're talking about here in the ecosystem of clinical investigation. It's really building a culture of excellence, learning to adapt and innovate, developing deep relationships, recognizing that we're doing this for patients, but we should have some fun on this journey. And I want to personally thank Bill Zogby, who was instrumental in helping me move forward with becoming the journal editor of Jack Heart Failure. And so the final remarks I'll give you, this was one of my good friends, the head coach of Duke football. This was an amazing situation where Duke upset Notre Dame a couple of years ago. But he said, and this is my youngest son here, who was the film manager for the football team at Duke. Chris, all you can do is leave the place a little better than you received it, and that's what I consider success. And I think that's a really nice way to think about your career and think about how you can keep moving things forward. So I want to thank you for your really the opportunity to speak to you today. It allowed me to reflect on a complicated journey of a lot of negative trials, ones that one could have thrown in the towel and been frustrated and moved on into a different world. But I think we learned a lot, and there's a lot more work to do. So I hope that you all continue in your journey to take excellent care of patients and ask questions along the way.